Hi, everyone. I would like to present my first CIMMS case study with Robin's mentoring. My name is Sheena Colhoun and I'm clinical specialist OT hand therapist in the Western Health and Social Care Trust in Northern Ireland. So my case study, this lady had a diagnosis of an undisplaced fractured right distal radius of her dominant hand. Her date of injury was the 5th of October 2020. History of presenting condition, she had a simple fall on outstretched hands in her kitchen and was treated as usual in a conservative approach in a cast for 5 weeks. She was referred to hand therapy after removal of plaster in November due to significant swelling stiffness in her fingers and wrist. Patient complained at the time of shoulder injury, which was subsequently diagnosed with adhesive capsulitis and treated with a steroid injection in January 21. At this stage, she was also then diagnosed with CRPS due to lack of progress, ongoing pain, swelling and stiffness. This patient was treated by my colleague from November 20 until April 21. Looking back at her initial assessment, it was documented that she presented with significant swelling, purple mottled skin, hand in a very protective extension posture, or the whole upper limb, very protective, no functional use, and very limited active range of movement in her hand and wrist, and I suspect in her shoulder and elbow as well. It was documented that she had a previous history of trauma, history of violence, and her family demands that impacted on her engagement in therapy. So in May 21, I reassessed her and took over her case. Her range of movement at her wrist was very good. However, she had minimal change in her finger flexion and very limited functional use of her right dominant hand. She had still a 6 centimeter flexion deficit, but there was no signs of CRPS. It was just chronic stiffness, and her shoulder pain remained more significant than her hand pain. So I feel that this had a big impact in her progress, and she had been seeing physio for her shoulder on and off to right as well. So treatment prior to CIMMS, she had the usual traditional therapy, including regular tendon gliding, active and passive range of movement. She had her home exercise program for her wrist and fingers, joint mobilization, K-tape, edema gloves for swelling and neuralgia pain, like extensive desensitization program, heat treatment was always used with a wax bandage and soft tissue massage. She had static progressive flexion splints. She fluidotherapy, shoulder pulleys, functional integration advice, and encouragement to speak with a counsellor for previous trauma, and some CBT techniques in chronic pain. She just was always very slow to progress. Heat treatment, her passive range of movement improved in each session. However, there was never any carryover to the next session. Patient was often feeling very frustrated by the lack of progress and had frequent cancellations. Patient was quite honest about her minimal compliance with home exercise program, and she had this belief from the start that her hand would not get any better. And even when she could see her range improving with heat and passive stretches, the next time she came in, there was never any carryover, and she just felt this was the way it was going to be. Her range of movement had improved to about 3 to 4 centimeter flexion deficit, but she was still very much left hand dominant. So in November 21, I completed the CIMMS course and persuaded her to give it a try, as we're now 1 year after her injury, and her wrist actually was doing very well, as it was an undisplaced fracture. I encouraged her to watch Robin's videos, and at this stage she was willing to give it a try, as she's tried everything else. So these are her first photographs before the SINS technique was carried out. You can see her range of movement here on the dorsal view and the lateral view. So she's got 3-4 centimeter flexion deficit with reasonably good wrist extension. There's no obvious swelling in her hand, just stiff. So to play the video.
Right, keep going into that full fist as much as you can, and out straight again. Into that full fist as much as you can. So we can see that this lady has a dominant intrinsic plus pattern, and she's definitely got tightness of the extrinsics and the intrinsics as well. Whenever we hyperextend here and come into that full fist as best you can, so bend that finger down as much as you can, and then out straight. Okay, bend it down again, and out straight. Okay.
So her first cast, I placed her in an intrinsic minus cast, and I wasn't sure how she was going to get on with the weight of it, as obviously her shoulder was pain was quite significant as well. But she was happy enough, and I rebooked her within a week for her follow-up appointment. I advised her to complete long, slow stretches of her individual digits. Robin's feedback that this should have been completed together to get better strain on the muscle belly. And obviously the cast edges should have been a lot neater and maybe lined with tape around the edges.
Okay, so exercises, they need to be done every hour, as much as you possibly can. And like I've said with you, we're going to follow these dots. We're going to try and match up the dots at each finger, and it's long, slow stretches, so you're pulling down with your index finger as much as you can. So come, bend your index finger, keep going, and hold that for a good 15 seconds. And you're doing this every waking hour, or as much as you possibly can in the day, to try and redirect the force to those two end joints of each finger. And the next one, keep going, as much as you possibly can. And then up straight, and it's as important to go up straight as it is, you know, to bend down. Okay, go again within the ring. You're trying to aim for that dot. Keep going. And then up as straight as you can. Back down again with the little one, and pull down as much as you can over the cast, and aiming for that dot. And then up straight as much as you can. And then even throughout the day, you're bending them as much as you can, and as I say, it's all over that active, constant movement as much as possible. Bend them all down together. Keep going. And up straight again. Okay.
So this lady wore it for the first week, and I thought she got on much better than I was expecting. She reported she was very compliant with her exercises. However, her shoulder pain, she had no sleep, and she just was feeling claustrophobic in the cast, so she just wanted it off. She could see a difference after the first cast came off, but still didn't want to continue with it. So she agreed to try then the short cast intrinsic minus and she wore that for 2 weeks. I felt that it was okay to continue with this as she had good wrist extension, but maybe her MCP joints needed to be in a bit more hyperextension.
Okay. One at a time, just hook and pull that over and hold for a good 10 to 15 seconds. And then straight again. Middle. That's it. Keep going. Good. Keep going, keep going, keep going, keep going, keep going. Great. And then up straight again. The ring one. Pull down. Come on. Come on. Keep going, keep going, keep going. Well done. And now for the little one. Keep going, keep going. Well done. So you're doing that every single hour, and this is on all day long. Yeah. So the only time you are taking it off is at bedtime. Alright? Yeah.
And then from there we progressed to a third cast, which was an intrinsic plus. I would have preferred to have got this into her wrist as well, however she just didn't want, she wouldn't agree to it. So I made her a short intrinsic plus cast, and she alternated between this one and the intrinsic minus, so 50% of the time she felt that this worked best for her. Obviously she could take it on and off, so I'm not sure how compliant she was as time progressed. But after wearing cast for another, so in total she had 4 weeks of cast, she was now making a much better fist. Her index and middle finger were touching the palm of her hand. The little and ring were about 1 centimetre away. So her range of movement, patient DNA'd over Christmas and January, so whenever she came back, her range of movement, there was no real change. She still had that 1 centimetre flexion deficit at the little and ring finger. So it just shows she made much greater improvement with the Sims rather than being left on her own to do her home exercise programme. So this was her final range of movement.
As much as you can, Catherine. Keep going, come on. Hold down, keep going, keep going, keep going. And out straight again. Back in again. Keep going. Pull in, pull in, pull in. Keep going, keep going, keep going. And out straight again. Back in again. Keep going, keep going, keep going, keep going. There we go. And out straight again. And make that full fist again. Keep going, keep going, keep going, keep going.
Until it was Christmas time, because she had, every time she came in she had a different colour of nail varnish, and this was nice and red for Christmas, and she would not have short nails or have no nails. And sometimes I feel like this impacted on her progress as well, because the nails got in the way. But in February, whenever she returned, her range, she maintained what she gained from the Sims technique, and then after that she did not come back. So on reflection, I wish I had tried Sims earlier. She definitely made faster progress in 1 month of Sims, and that wasn't even the full cast, than she did in 6 months of traditional therapy. I wish I had changed her first cast to the bivalve rather than jumping straight to the short cast, because maybe she might have been more compliant and we might have got her into that full fist. Where our department's located in the Western Trust, we are a little bit further away from the fracture clinic, so we had poor access to a cast saw. So that's just something that I'm working on moving forward. If I'm doing a little bit more casting. I definitely need access to a saw, so we're putting in a business case for this at the moment. Everything is a little bit slow in the NHS. You just can't buy it and bring it in yourself. I feel that the Sims technique originally was going against all of my natural instincts. The fear of putting her into a cast and causing more stiffness was definitely originally there. However, I feel because it's going against your natural instincts, you really do reinforce the importance of home exercise program and that constant movement. So that emphasis, I think, really did help with her compliance. And as you're almost treating it almost like a research project, she really had to consent to having the cast on before starting the Sims technique. And obviously this real redirection of force to the distal joints just allowed her to focus only on those and really get that brain engaged. In this case, it was a bit frustrating, the lack of carryover, as her passive range of movement was better than her active, and I think with her, she just was very slow to progress because of her belief the whole way through that she would never actually improve, and this really impacted on her compliance. And I also feel that early diagnosis of CRPS impacted on this belief that she would never really improve. I'm not sure whether she had CRPS because I obviously didn't see her at the start, but whenever I took over her case, to me it was just a chronic stiff hand. Okay, so I look forward to any feedback and just in the future using it a bit more and hearing more case studies and uses of the casting, and also maybe changing my practice from thinking of Sims as a last resort for stiffness, maybe not waiting as long as I would maybe in the past. Okay, that's it.